2-minute anaesthesia in critical care, the placenta. The placenta provides a physical link between the mother and the fetus. It weighs approximately 500 grams, has a large surface area of approximately 15 meters squares, a diameter of 20 centimeters, and is relatively thin at 3 centimeters. It has a significant blood flow during pregnancy. This video will cover a range of topics including placental function, physiology, anatomy, and anaesthetic considerations. The placenta has a range of key functions. Those include gas exchange and removal of waste products, metabolic, as it contains cytochrome P450 molecules, the transfer of key molecules including drugs, for example glucose, amino acids, electrolytes, water-soluble vitamins, but also immunoglobulins. It has a secretory hormone function for growth and development of the fetus, including growth hormone, HCG, estrogen and progesterone. The placenta can be divided into 3 sections. Firstly, the chorionic plate, which is composed of connective tissue and fetal blood vessels. The umbilical vein and artery differentiate into smaller vessels to form the chorionic artery and vein. Next, we have the central layer, the intravillous space. This is a key connection between the fetal and maternal blood supplies. The fetal blood supplies further subdivides to the main stem villi and then the chorionic villus. Maternal vessels enter this space. These are known as the endometrial artery and vein, and due to the close proximity of these vessels, this allows exchange of products. The next layer is the basal plate, composed of the delucida basalis, connective tissue and maternal vessels. It is not accurately drawn here for simplicity, but it bulges into the intravillous spaces to increase the surface area for gas exchange and product exchange. The final layer is the myometrium, which is a smooth muscle layer of the uterus which is able to contract. Uterine blood flow significantly increased in pregnancy from approximately 100 ml per minute in the non-pregnant patient up to 900 ml per minute, or 10% of cardiac output in pregnancy. This increase in flow is secondary to an increase in vessel caliber. Uterine blood flow is equal to the uterine artery pressure minus uterine venous pressure divided by the uterine vascular resistance. Due to the lack of arteriolar resistance vessels, there is minimal physiological regulation of uterine blood flow. Therefore, the relationship of uterine blood pressure and flow is linear. A range of vasoactive mediators affect flow. Those which cause vasodilation include beta-2 agonists, nitric oxide and adenosine. Vasoconstriction can be caused by adrenaline, noradrenaline and vasopressin. A range of different factors can increase placental transfer of agents. These include increased lipid solubility, a higher concentration gradient, low protein binding, low molecular weight, and low or minimal ionization. There are a range of different mechanisms by which molecules transfer across the placenta, the most common of which is simple diffusion. This is a result where the molecule either moves between or through the cell down a concentration gradient and does not require energy. The next is facilitated diffusion, where the molecule also moves down a concentration gradient using endogenous carriers. Active transport, unlike facilitated diffusion, requires energy in the form of ATP via a carrier protein. An example of this would be amino acid transfer. And finally, pinocytosis. This is slightly different, whereby the cell membrane engulfs the molecule and transfers it through the cell before releasing it on the other side. An example here would be the transfer of IgG. The ability of anaesthetic agents to cross the placenta can either be rapid, variable or non-significant. Those agents which rapidly cross the placenta are highly lipid soluble. These include IV induction agents, inhalational agents, opioids, atropine and benzodiazepines. Local anaesthetics have a variable transfer, as they are required to be absorbed systemically prior to transfer, which does occur but usually in small amounts, unless they're directly injected systemically. There's also a risk of ion trapping. Those agents which have minimal transfer are those of glycopyrrolate and neuromuscular blocking drugs, as these agents are both ionized and therefore have minimal transferability.